So we will start with the shoulder joint. Just to give you a brief, every joint will be examined in the same way. So number one is look, feel, move, and special test. All joints of the body will be examined in exactly this way, and you should have the same process for all joints. So if we start with the shoulder, the first thing that we do whenever you're going to examine the shoulder is that you take consent. You introduce yourself, you take consent for the patient for examination, wash your hands, and describe to the patient exactly what you're going to do to the patient. Second most important thing is exposure. So you have to have proper exposure for any joint that you're going to examine. So in case of shoulder, the patient should be either in a vest or the upper body should be fully visible, so you can see the bones and the muscles around the shoulder clearly. So you stand the patient in an open place, and the first thing, as I said, is look. So you walk around the patient looking for any deformities, any scars, any swellings, or any abnormal findings that you can see from the front, from the side, or from the back. So you should have a clear picture, and while you're examining, you should be able to describe and understand what's going on. Second thing is feel. When you start to feel the shoulder, you should have a similar process that you do in every case. So what I prefer is that you start from the sternoclavicular joints here, and then you feel the clavicle, you go out to the AC joints, you go to the acromion, you go to the humeral head, feel the muscles in the front of the shoulder, back of the shoulder, go back, feel the trapezius, feel the scapula, feel the muscles around the scapula on both sides, and then you come back to the front of the patient. So that completes the feel part of the joint. Then comes the move. Now movement, sometimes the patient may not understand exactly what you want him to do or you want her to do. So I prefer that I stand in front of the patient and I show the patients all the movements that I want them to do. And then I ask the patient to do exactly like I do. And when you're checking it, you have to write down what degree they're moving that shoulder to. And you have to document it properly as well. The movements that we check for the shoulder include abduction, flexion, extension, external rotation, and internal rotation. And in the subsequent videos, obviously, we'll show you how exactly we do these tests. So after move, it comes to the special tests. So in case of shoulder, the special tests that we do are for the rotator cuff. There are 4 rotator cuff muscles in the shoulder. There is supraspinatus, infraspinatus, teres minor, and the subscapularis. And there are tests to assess each of these rotator cuff muscles. For the supraspinatus, we do the MTCAN sign, which we will show you as to how we exactly do. You do a resisted external rotation for infraspinatus and teres minor. And for the subscapularis, you do a lift-off test, or you do a Napoleon belly press sign. The second test, special test we do in the shoulder is for impingement. And there are 2 things. One is the impingement sign, in which you rotate the shoulder in a position that gives pain to the patient. If the patient has subacromial inflammation or a bony spur or rotator cuff inflammation, they will have a positive impingement sign. The second thing is impingement test. Impingement test is done when you inject the subacromial space with a local anesthetic, and the pain should actually disappear. If the pain disappears, this suggests that the pain is coming from the subacromial space, so it is a positive impingement test. The third test that we do for the shoulder is for AC joint arthritis, and that's called as a scarf test, in which we adduct the shoulder or the cross arm adduction, and the patient will have pain in the region of the AC joint when they do this test. The fourth test that we do is speed test, which is for biceps tendinitis. So you ask the patient to put the hands up straight and then lift it up against resistance, and the patient will have pain in the region of the biceps tendon, and this will suggest that they have inflammation of the biceps tendon. The last test that we do for this is apprehension and the relocation test. Apprehension test is done in patients with recurrent dislocations of shoulder, and they have damage to the anterior labrum and the anterior structures of the glenoid, and they feel when you externally rotate the shoulder that the shoulder is going to dislocate to the front. So when the patient is apprehensive, you actually stop rotating the shoulder any further, and then you press the shoulder from the front to stabilize the humeral head, and the patient will now allow you to go further with the external rotation of the arm. and this is called as a relocation test or Job's relocation test. So these are the tests that we do for the shoulder. So this is Dr. Shahir. We're going to examine his shoulder today, and we will see how we're going to do a proper examination of the right shoulder. So as we discussed, first of all, you have to introduce yourself. Hi, Dr. Shahir. I'm Dr. Hassan. Is it okay if I examine your shoulder?
Yes.
Do you have any pain anywhere?
No, I don't.
So then the examination will start. So you've introduced yourself, you've taken the consent from the patient, you've asked about pain, you've washed your hands properly. It's very important, vital that you clean your hands in the exams before touching any patient at all whatsoever. The start, as we said, will be look, feel, move and special test. So first of all, you stand an open patient in an open place and you look at the shoulder from the front. You're looking for any swellings, any bruising, any muscle wasting, any deformities, any scars. And then you go around the patient and then you are seeing from the side and behind to see if there's any problem with the back musculature, any scars in the back, any abnormalities in the back, and then you come back to the front and that's it. So the inspection is complete. So look part of the examination is complete now. Second is the feel. So you should have a process, as we said, that how you start. So we start from the sternoclavicular joint here. So what I do is I just go to both sides, starting here and then examining clavicle, the AC joints, the front of the shoulder, the humeral head, the sides, the back of the shoulder there. Then I turn the patient around and I go to the back part around the scapula, feel the rhomboids, feel the muscles on the medial side of the scapula, feel the central part of the spine. Going to the right side now, same, feeling the scapula, the muscles around, and then we ask patient if he has any pain anywhere. It's very important to ask for any pain. Do you have any pain, sir?
No, I don't.
And then similarly, I'm coming back to the front. So that's the palpation part of the shoulder also completed. Now movement. It's very difficult to tell the patient to do a certain movement. So the best thing in the shoulder is that you show the patient what you want him to do and ask the patient to do exactly like you want him to do. Can you please follow my movements? Just slowly on the sides, raise the hands up all the way to the top. This is an abduction and you check the range of motion and you have to document the range of motion of abduction. Okay, slowly down. Do you have any pain doing this?
No, I don't.
No pain. Second is flexion. So you get the patient to take the hand up all the way. So this is flexion. Now we have to write it in degrees or mention it in degrees. This is 90 degrees. This is 45 degrees. This is 30 degrees. And this is full. The left hand is fully up. This is about 170 to 180 degrees. Okay, down. That's fine. Thank you. So next is external rotation. External rotation of the shoulder is with the hands on the side, elbows locked on the side of the body, and then you ask the patient to take the hands out like that. This is external rotation. It's measured in degrees. The normal range of motion would be around 60 to 70 degrees in most people. It is more in females because they are more lax, they have more flexibility. So this is external rotation, how we do it. Okay, thank you. To do internal rotation, the way to do it is this. You ask the patient to take the hand up all the way to the top and see what level is the thumb going. Can you please do that,
Yes.
Shahid? So I can see how much it's going up. So we can see that the thumb or the highest point, which is the fingers here, is going up to the level of the inferior angle of the scapula, which is at the level of around T7 to T8. And if this hand is coming up to here, this is about T10 to T12. This is L1. This level here is L5. This is sacroiliac joint. So you have to be able to mention the level where it is going. And can you please repeat it with the other
Yes.
side as well? Similarly, you get him to repeat both sides and then you have to document how much he's able to internally rotate the right or the left shoulder. Thank you. So that's the range of motion of the shoulder. Now coming to the special test for the shoulder, there we test for the rotator cuff. So we will start with the rotator cuff muscles. Empty can sign is used to check the supraspinatus. Shahid, can you please put your hands up like that and thumbs pointing down and arms in line of the scapula. Now thumb is down. This is the empty can test for the supraspinatus. Push the hand up and we check if the patient has any pain, and we look at the face of the patient to see if he is complaining of any pain. Patient with supraspinatus inflammation will have pain doing this test. Okay, thank you. Now for infraspinatus and teres minor, it is resisted external rotation. Can you please put the hands up like that, elbows by the side, and push your hands out when I ask you to. Okay, push your hands out please. Okay, now he's pushing against my hands, and this I'm testing infraspinatus and teres minor. If the patient has inflammation in these two muscles, he will have pain trying to do that. Thank you. The next test would be the push-off test for the subscapularis. And you ask patient to look at you and to do exactly like you want him to do. So you turn around and you tell the patient, can you please push your hand like this? So can you please do that? First with the left hand. Okay, push my hand away. While you're doing it, it's very important that you put your hand on the shoulder of the patient so the patient does not fall forward. Because if you don't have your hand here, the patient may fall forward trying to push the hand out. Okay, push my hand, sir. Any pain doing it?
No.
Okay, this is for subscapularis. Now do it with this hand. Push my hand away. Any pain?
No.
Okay, this is the test for the subscapularis. So we have tested all rotator cuff muscles. Now some patients are unable to do internal rotation because of the pain and the decreased range of motion of the shoulder. So for these patients, we have the belly press test, the Napoleon belly press. So can you please put your hands like this in front of your tummy and push it backwards and push the elbows forward. So we ask the patient to do that, and then gently you push the elbows back and see if the patient has any pain. Any pain?
No.
Okay, so this is another test for subscapularis in patients who cannot internally rotate their shoulders. Now, the second special test would be for the impingement. Now, impingement, there are two things with impingement. One is impingement sign, other is impingement test. So for impingement sign, you ask the patient to abduct the shoulder to 90, flex the elbow to 90, and internally rotate. If the patient has got pain during this test, it means that it's a positive impingement sign and the patient has got subacromial impingement. You repeat the test by moving the elbow forward and again internally rotating. And if the patient still has pain or has more pain in this position, it is a positive impingement sign. Now the other thing is impingement test. In impingement test, we do injection of the subacromial space with local anesthetic, and the patient pain will go. If the patient's pain is gone, it means that the pain or the pathology is in this region, which is the subacromial region, and it is a positive test. So that is the impingement test, and the first one was the impingement sign. Now, another test for the shoulder, the special test, is for the biceps tendinitis. In this, we do the speed test. Can you please put the shoulders up like that, both of them? Okay. Now, against my hand, push your shoulders up. Push up. Now, if the patient has biceps tendinitis, they would complain of pain in the region of the biceps tendon here, over the shoulder. So that's a test for the biceps tendinitis. Okay. Another test is for the AC joint arthritis. This is called as the scarf test. It's cross arm adduction of the arm. So if the patient has got a pathology in the region of the AC joint, you ask the patient to put this hand, the right hand, onto the left shoulder like this, and then you gently push it onto this side. If the patient has arthritis of the AC joint or has any AC joint pathology, he will have pain when we do this test. So this will show us that he has got AC joint arthritis or some AC joint pathology. Okay. So the final test for the shoulder is apprehension test for the shoulder. Apprehension test is positive in patients with recurrent dislocation of the shoulder. Now the most common dislocation of the shoulder is anterior dislocation. If it happens in a young patient, they continue to have recurrent dislocation because the anterior structures of the shoulder are damaged, namely the anterior labrum and the capsule. So in a patient with the recurrent dislocation or instability of the patient, they will have a lot of apprehension if we try and externally rotate the shoulder. So a patient with the recurrent dislocation will not allow me to do this movement of the shoulder. They would stop me from doing it and they will feel very apprehensive. So apprehension test will be positive in patients who will not allow me to go backwards like that. And another test to confirm that it's actually the problem of the anterior structures is to do a relocation test or Job's relocation test. In this test, we stabilize the front of the shoulder so that the anterior labrum, which has been damaged, is now stabilized with my hand. And my hand is pushing the humeral head backwards. So the patient will feel more secure and he will not feel the shoulder being dislocated anteriorly. So now if I do the same test and externally rotate the shoulder, the patient will feel no apprehension and will allow me to do this movement. It's very important that when we finish this test, we put the shoulder back in the neutral position and then take the hand off. Because if we take the hand off with the patient's arm in full external rotation, we will remove the anterior stabilizing factor and the shoulder may actually dislocate during the examination. So it's vital that we put the shoulder back in neutral and then remove the hand from the front of the shoulder.